we'll have a Q&A after as well. Yeah.
All right, so I get to be the moderator. So why don't we go down and do an introduction of each person. We'll start with you, Dr. Crichlow.
Hello, first I want to say thank you for this opportunity, really appreciate it. I'm Dr. Renee Crichlow. I am a proud family physician. I've practiced full spectrum for about 25 years. And I am currently the Chief Medical Officer at Codman Square Community Health Center and Vice Chair of Health Equity for Boston University, and I lecture at Harvard Chan School of Public Health.
Clearly an underachiever.
Yeah.
Yeah, I want to also emulate, thank you very much for inviting me to this panel. It's truly an honor. I'm really excited actually about it. My name is Anila S. I am an OBGYN. I practice at New England OBGYN. I've been practicing for about 10 years. And I also lecture as well at the Harvard Medical School. I teach about menopause, abnormal uterine bleeding to the second year medical students. And I'm part of the Boston OBGYN Society as well as their vice president. I think that's it.
Another underachiever.
And I'm Andrea Giancontieri, again, founder and CEO of the Whiny GYNie. The Whiny GYNie is a patient-led, patient-focused, patient-positioned information and advocacy company. So what I do is on social media, I'm one of those people. I actually have conversed a lot with many of the people in this film. I talk about my menopausal experience and how I went to 9 different providers before the esthetician at the threading salon told me that what I was experiencing was hormones, or a decline in hormones. So yeah, that's a true story. So 9 different providers until the nice lady at the threading salon said, "Oh honey, it's the hormones." And that prompted rage and a decision to try to advocate and help other people to have a better experience than I've had. And what that comes with for me is a lot of advocacy work. I've testified and supported 2 pieces of menopause legislation here in Massachusetts. I will be in New York. Thank you. I'll be in New York to help them. Mom, I might need you to watch the dogs. To support Assemblywoman Rosenthal for her advocacy in Albany at the beginning of March as well.
Awesome. Yet another underachiever. I love it. All right, so we have these amazing experts. So let's, so I'll just ask a few questions. We'll get some conversation going and think about your questions because you guys are up next. So let's talk about HRT. Let's start with that question. First of all, how many of us are on HRT, if you're willing to share? I got the patch. Okay, so we have some people on here. Boy, that one study really kind of messed us up. So let's really clarify what the scoop is with HRT. We can start with you, Dr. Crichlow. And I will say, I got to be in the room when they made the announcement about removing the black box warning. It was a very exciting day. But it's actually led to a lot of confusion. So we'd love to have you kick that off.
Well, I think number one, I don't use years. I use levels. I'm level 58, which is awesome.
I like that.
And as a level 58 doc, I will tell you that I was in medical school. I remember it was in second year, and we had an endocrine lecture. And the endocrine lecture, it was about HRT. This was in 1995. And he's like, HRT, all you need to know is it should be in the water.
Wow.
Yeah, that's what it was like. If you were a woman in the 90s, mid-90s, and you were even hinting at any perimenopausal symptoms, boom, you are an HRT. So fast forward, I finished medical school, I'm in my residency, and I graduate, and I'm teaching at University of California, family medicine and OB-GYN. I'm the clinical director for the breast health clinic, and boom, they dropped the WHI, and instantly, everyone was pulled off their hormones. Instantly. It goes from something that should have been in the water to no one goes near it. And you have to understand, my career follows this actually quite well, because as a young faculty member, I was one of the last generations that learned about HRT. And I have been teaching for 25 years, and I will tell you that the generation that grew up like myself, we weren't teaching HRT because black box means lawsuits.
Yeah.
And that's the thing. It's like you are inheriting a generation of doctors that were not taught this at all. And the best news about it is the black box warning being pulled back gives a very big incentive to have shared decision making. But you have to understand, it was last year. It was last year. So we have a long way to go. Generations of doctors have grown up without learning about this. And we used to think it should have been in the law.
Wow.
I actually am so thankful that I'm sitting right next to you because I'm in that generation that did not learn about HRT in medical school or in residency, actually. My education on hormone replacement therapy came as an attending from a woman who is actually a menopause provider in New York, and she actually called me into her office after the day was over. She was getting ready to retire, and she said, listen, I need somebody to take on my patients, and she sat me there for 2 hours, and that was my whole lesson on hormone replacement therapy. After 4 years of medical school and 4 years of residency, I got it as an attending. And then I moved to Boston, and I inherited a whole panel of patients, again, from a retiring doctor, and that's kind of what really drove my passion for hormone replacement therapy. But I agree. I mean, I think there's been a lot of swinging back and forth, and I think we're now kind of heading in a more reasonable direction. There's a lot more work to do and a lot more education to do, but I think we are probably heading the right way. I don't know if that answered your question.
Yeah, I think it's great perspective on how much it's changed. I think that's really helpful. And that stat about only 5% are actually on HRT, that's crazy. That's just, to me, insane. Yeah, go ahead.
It's about 14% in the UK. So
Oh,
we're lagging
okay.
pretty far behind. So in other countries, Australia, the UK, they're much further ahead than we are. We have some catching up to do.
Yeah,
Yeah.
absolutely. Okay, so the other thing that I think is really interesting is younger people in their 30s, they were saying they're coming in asking questions, or maybe even starting to have some symptoms. And then, another side of it that we don't really talk about, but it's very important, is younger breast cancer is actually increased in younger women now, and some are then forced into menopause early too. So for a lot of reasons, there's sort of the younger side of things. So what advice do you have for folks, like what can they do in their 30s, 40s, 50s, whatever, to maybe minimize symptoms, to help address this heart disease? There was a lot of conversation on that. So why don't we start with you this time?
I do have a lot of patients now who are coming in younger reporting symptoms, and I actually think it's great because they're kind of getting ahead of it. The documentary did mention that social media is our biggest source of information, and I do think that can have a double-edged sword, but in this situation it can really help highlight some of the discrepancies. To answer your first question about what you can do, I'm not a big supplement person. I just say healthy diet and exercise, maintain a reasonable lifestyle, don't pick up any crazy habits, in your 30s, it's probably not great for you. And then, I do think it's reasonable to start hormone replacement therapy in the perimenopausal period. I would say that the Dr. Haver in the documentary kind of touched upon using it as preventative medicine. The American College of OBGYN and the Menopause Society have never said that, and I don't think they will say that as a preventative way. So I think that's going a little bit too far, but I do think it can help with a lot of things as a side benefit. Your specific point about cardiac disease, in your 30s, most 30-year-olds don't have pre-existing cardiac disease. So the reason why they have that timing hypothesis of starting it earlier rather than later is because if you give estrogen when somebody does not have pre-existing coronary artery disease, it can have a net benefit. It can be cardioprotective. What the documentary didn't go into was if you actually have pre-existing cardiac disease, it can actually be worse for you. It can cause plaque instability and increase your risk of coronary artery disease. So there's actually a calculation that you can even do yourself at home if you have some of the right numbers. If you go on the American Heart Association, you can put in your age, your gender, your race. If you have a blood pressure number, put in the blood pressure. If you have a recent lipid profile, you put in those numbers. You can also do it with your doctor if you're not able to. And it can actually give you a cardiac risk score. The same thing applies for breast cancer as well. There's something called a Tyrer-Cuzick score that I do in my office with my patients. It's also available for free online. You just Google Tyrer-Cuzick, and I use the MagView, which is the first thing that comes up. And you just put in your age, your menopause, age of menopause. There's a bunch of history questions, family history of breast cancer, and it can give you a calculation of your breast cancer score. So I think that's important to do to kind of evaluate your risk even in your 30s.
I'll sort of comment a little bit on that. One of the challenges around some of these predictive models, though, is that how do I say this? I want to say this nice because I don't want to say garbage in, garbage out. But the fact is, a lot of these tests, a lot of the models were done large populations of white women and very small populations of non-white women. In my first year on faculty, I was a Susan Komen International Cancer Fellow, and I did an evaluation of the Gale breast model. And I basically ran white women through and then I ran black women through, and then I was like, hey, let's just switch the race. And it dropped their risk considerably just by changing their race to black. And so I emailed, back in the day, I emailed the author and said, hey, I'm curious, can I talk to someone about how you guys built this model? And he's like, oh, our statistician's retiring, here's his email him. I'm like, okay. And I'm like, he's like, call me. And I call him and it's like, hey, how many black women were in the model population? And he's like, 17. I was like, you had 17,000 black women? And he's like, no, 17. 17 women in the model when they first did. And those are the kinds of things that are dangerous. It's very important for us to engage in shared decision making, but one of the things we have to be really clear about is we won't have all of the data. It is important to have the high risk, the low risk, and your family risk. These are very important. They help with shared decision, but do not be independently shifted by like one thing. And one of the things I thought that was done really well in the documentary was the collection of symptoms is a really important, what was that they said? I just don't feel like myself?
Yes.
I mean, I can't tell you how many times I've heard a patient say, and that's when you just got to sit up, because something, we need to keep going until we find it.
Yeah. What do you see with the Whiny GYNie? I mean, what's your perspective on this?
Yeah, so I have a couple of different things. I had the privilege of screening this before this evening and got to sit with it some. There are distinct differences between this film and the one prior. This one, I think, added a lot more information about other health conditions, relationships, and had a much more diverse audience, which I think is appreciative, and they all are appreciated, and they also had a lot of doctors from a lot of different disciplines. So I think that was interesting. On the social media front, as we were saying, and one of the people's in the room tonight, but I am approached by a supplement company to promote their products at least 3 times a week.
Wow.
And as someone with a okay social media presence, right? So I'm constantly contacted by people who want me to pitch their products, and I'm very cautious about that. I want things that are third-party tested. I've not signed on with anybody yet, but third-party tested. I want proven, kind of proven data. I want to know that something's working for someone, and I don't want to just, go out there and pitch things. It's, it'd be a really easy way for me to generate some revenue, but my ethos isn't allowing it unless
Thank you for that.
something's happening. Sorry.
Yeah.
But yeah, also, they were talking about patches. I want to touch on the patch shortage. If anybody is on menopause hormone therapy or hormone replacement therapy and is prescribed estradiol, whether typically right now it's in patch form, there is a nationwide, even global shortage of patches. And so people have to work with their providers to figure out how, because we're going to have more women these films and the FDA black box warning are not what's driving women to seek hormone therapy right now. It's more of a compliance thing, is my understanding, as people get the medication and the black box warning will eventually not be there. I had heard Q3 of this year, maybe before the packaging has really changed. It's not that the black box warning is gone. That's not what's driving women. It's just maybe they're be more compliant. But more awareness will drive more people. More social media will drive more people. So we need to really be advocating and pushing our pharma companies to make the drugs that we need to live well.
Yeah.
And so we don't have one of the people who works with Women's Health Advocates. I'm a volunteer with Liz at her organization. It's the HRT Club right now. They still have patches. They're not paying me, I can just say that. Also, to secure your medication, you should probably also maybe avoid the chain pharmacies and try and go with your local independent pharmacy. They have the opportunity and the ability to source from multiple distributors, where, say, your chain pharmacies are only sourcing from one distributor where they have the opportunity to make the most revenue, right? So they have a bulk deal. That distributor didn't bother to buy meds, so women are suffering. So your local independent pharmacy or something like a mail order or the HRT Club could be a good option. So I just wanted to touch on that.
Thank you, that's very helpful. I want to ask all of you, so we heard about these two online risk, what do you call it, tests, screen?
It's like online risk calculators.
Calculators.
Yeah.
How many of you knew about the breast cancer calculator online? Okay. How many of you knew of the heart disease? Okay, so you're right, you're pretty educated. I'm just saying, like, we need to get the word out on that. I knew about the breast cancer one because of Olivia Munn, because she was all over the place talking about it, but I did not know about that heart disease one. So, yay, all of you, and now we all know we're gonna go online and get our risk calculated. I think that's awesome.
We're also going to be mindful of what Dr. Crichlow says about
yeah.
some bias in that.
That's true.
Yeah, I was actually going to say, I'm so glad you brought that up, because a calculator is exactly that. It's a calculator and it's a percentage. It's not God. So, you know, I've had patients who, when we do their calculation, their breast cancer risk comes up as above 20%, which is high, you know, for the Tyrer-Cuzick score. It doesn't say, oh, you can't have HRT. What I do is I say, okay, well, your risk is elevated. Let's keep a closer eye on you. So instead of doing yearly mammograms, now for those patients, I'm going to maybe throw in an MRI every year, every 6 months or something as a supplementation. So it's just kind of a way to figure out who we should keep a close eye on, as opposed to a yes or no answer.
Okay, that's helpful. Let's talk about like data and bias, and because this is big. Wearables, Aura just had this big announcement. They're doing a huge shift into women's health. So there's so much happening here. But if we start from the beginning with inaccurate data, inaccurate representation, then we're all going to be screwed. Like even worse than where we are now. So what do we think, especially clinicians? Like how are we using data? How can we address this bias? What are your thoughts on that? Whoever wants to go first.
Honestly, that was one area where I was like, I don't really know I don't wear a wearable, so I don't really know too much about it. I think it's interesting. I think that the AI being, coming in is very interesting. But to your point, I think we have to be very careful about the data, because it's not entirely predictive for everybody.
Okay, I'm going to throw down that overachiever thing again.
Okay, I like it.
I actually am a little bit of a national expert on AI and health equity, and mainly because a while back, my dad was a nerd. I'm just going to say it. My dad was a nerd. I'm an early adapter. As AI started coming up, I knew it was going to be a problem unless we got in on the ground floor. And that's one of the biggest things. That's one of the things that like every organization that is afraid of AI needs to be in on the ground floor talking about, hey, how are you making those choices? Who are your ethical people? And buying AI is another thing. It's like, okay, great, who is this tested on? How are you validating this? How often are you validating this? These are the kind of decisions we have to make at a clinical level and a hospital level, because healthcare is all in on AI. And a big part of what I feel my job is to do is say, you guys don't understand, if we don't help build this, it will forget us. That whole statement, if you're not at the table, you're on the menu.
Yeah.
Munch, munch. It's big. this is the kind of stuff that if we're not participating. So organizations like Whoop, Aura, Fitbit, all these organizations, a lot of them are like, you have to buy this in order to get the data. But the thing is, there is income inequity in this country. The vast majority of that data is going to be coming from relatively healthy, affluent
Exactly.
white people.
Yeah.
Yeah, and that's the thing. That's the thing that we have to keep in mind. But medicine, I gotta tell you, we are so used to doing that. Like EKGs, the EKGs that we're trained on are based on middle-aged 70-kilogram white men. That's the training that we get. And so that's when women, when we read their EKGs, they can seem abnormal or normal in ways that they're actually not.
Yeah.
So it is the garbage in, garbage out. Participating, organizations like the WHA, all those, the advocating and getting involved. No one sits this out. We have to be a part of it, or they're just gonna roll right over us.
Yeah. What do you think?
Yeah, I mean, so I use AI every day, and I see things that are coming through wrong to me that I know are wrong. I have a hormonal fat storage disorder. It's genetic. It's called lipedema, and I attended the lipedema symposium at Harvard Medical School last Friday, and I've educated myself a lot about lipedema, and I wrote something and I asked ChatGPT to just make it better, right? Which is usually what I do. I put in what I have to say and I say, could you just make this seem a little bit more coherent and flow a little bit better? And it started trying to validate what I had written and tell me that I was wrong. And I'm sorry, I'm not wrong. I know I'm right. And I was like constantly going through and I'm like, no. And then, or I'll do something with, hormone therapy, or, to develop a piece of content. Like I just want to punch up my script a little bit and it'll come back and it'll tell me things that I know are incorrect. And so what we have to know is that we have to validate everything. Like, I like when it sources a statistic for me when I'm like, okay, where did the stat come from about 31% of medical schools, right? And it'll spit out the stat for me and it'll tell me that it's a little bit wrong and a little bit nuanced and it's not this, it's this instead. And I find that to be a little bit helpful when I'm asking it to source a stat that I already know, but when I'm looking for it to help me punch up my argument and it tells me that I'm wrong or it gives me information that I know is incorrect, it's scary to me. That's kind of my perspective on the AI thing. You can't just take it as gospel. That's hard.
If anything, the human brain is more necessary now than ever.
Yeah, be more skeptical. Skeptical. Can't talk. Okay, so I'm going to ask one last question, and then it's up to you all. So I hope you're ready. All right. I know you have done some advocacy work, and that's my love language. So let's talk about advocacy, right? Because this is about advocacy for ourselves when we're in the doctor's office, for our loved ones, but it's advocacy in the public sphere. It's marching in Washington, in your state houses, it's talking to the candidates. Hello, it's election year, right? So there's so many ways to be active. So let's talk about advocacy. So let's go down there, we'll start with you, since you've got the background in it.
Yeah, so advocacy is really about understanding that if you're not involved, no one's going to pay attention to you. And this is a really important issue. That black box warning, when a doctor sees that, they're just like, all they see is a lawyer. And I can say that because my wife's a lawyer. But it's gone now. And I look at it and like my generation, Gen X women, my mom's not here. We're screwed. This should have been started 15 years ago. We don't have time to wait on this. And the big thing about advocacy is, Arthur Ashe would always say, start where you are, use what you have, do what you can. So there's people that are already working. There's legislation that are in play. We need legislation that says, docs need this much hours of CME. They do that for opioids. That was absolutely necessary. If we are going to be able to help this generation of women, we have to get this kind of information into the public sphere. And the other thing is, you can do it in the legislative place, but you can also advocate at the medical schools. You're like, hello, you guys are responsible for us. The warning is gone. What are you doing? Holding people accountable and saying, what are you doing? This is different now. What are you doing? And when you're advocating, it's a 3-step process. You start with a story, you throw in a little data, and then you have an ask. That's it. And the ask, the story is, we're going to lose a generation of women that we've left behind because of inaccurate science. The data shows A, B, C, and D. The ask, let's make it better starting now.
Love that. I hope someone got that on video, because that was perfect. Woo! Love it.
How am I going to follow that? That was beautifully said. I think I ditto +1 on that. No, I agree. I think we should be really just starting at the ground level. And, I think not everybody here is in the medical field, not everybody's a physician or a medical student, and so it really doesn't matter. You can start at wherever you're working and wherever your community is, where you're living. There is a menopause group in my hometown. It's a very small hometown that has formed, and they meet, and so it can happen anywhere. It doesn't always have to happen in a particular area. And then I think just like another thing that, I don't know if this was what you were going for, but even advocating for yourself as a patient. If you go in for your doctor's appointment and you voice your concerns and you're not heard, well then follow up either with that same doctor or go find somebody who you know will listen. And don't do this as your one doctor's appointment that you have a year. This is a separate issue, a menopause issue, perimenopause issue, that will be a separate consultation because it deserves the time that it needs. And so in my practice, my perimenopause, menopause consults are 30 minutes. It is double the time that I take for an annual exam because it deserves that much time. And so really advocate for yourself when you're making that appointment that this is actually what I want to talk about. I don't want to talk about my pap smear. I want to talk about this.
Yeah, I'd like to add to that. So first, advocacy is free. So if you want to write a letter in support of a piece of legislation, if you can't make yourself available to testify in person, you can absolutely do that. You can call your representatives. Those things are free. You can send a postcard. Okay, it costs a stamp. You can send an email. But there are things that we absolutely should be doing. And I'm going to just give the example of my total knee replacement. So I had a total knee replacement December 19th. Super lucky, this one. I have another one coming next month. And I got wind that my orthopedics office, or one of the other providers in that office, tells people to suspend their menopause hormone therapy. And so I wanted to get ahead of that and make sure that that's not what was happening to me. So I talked to 3 Menopause Society certified physicians. One of them's here. The other one was Dr. Barbara Hanna, who's the founder of My Menopause RX. And then the third is my own menopause provider, is Dr. Tara Iyer at the Fish Center. She's an endocrinologist. And then I have factor V Leiden, which predisposes me to blood clots. I have heterozygous factor V Leiden. So I also met with the hematologist. And not everybody can do that. This is all in my testimony in support of House Bill 4838 here in Massachusetts that I gave in January. But not everyone has the privilege, the time, or the relationships to be able to do that kind of self-advocacy. I brought all of that information to my orthopedics office, and they said, yeah, sure, you can stay on your hormone therapy. But had I not done that, I would have been advised to stop like every other woman who has gone to that practice. And my question was, and Barb Hanna is the one who posed this to me, is if I were premenopausal, would they have removed my ovaries before my surgery? And the answer to that is no. So I have done a lot of posting about that on social media. And then the other time, I've been an advocate my entire life. My brother is profoundly intellectually disabled. My parents advocated for him my whole life. That's what I got to see. And then I was the team representative to the County Council on Teenage Health and Sexuality. My mom who's here, used to have to drive me to those meetings. And my dad was the vice chairman of the board for the Center for Discovery in Harris, New York for 43 years before retiring. And so advocacy is, and my mom was the PTA, the person who made the costumes, the person who hosted the sleepovers, the person who drove everybody in a beat-up van to the movies. That's how I was raised. So when this happened to me, my mom's giving herself props. Good job. She came here because I told her we had some volunteers who weren't able to come, and she got in the car and drove from New York. So I'm a pretty lucky person. But I learned to advocate early, and I don't know how to only advocate for myself. So So now I advocate for everybody. But in 2 doctors' offices, I was denied care because of my factor V Leiden, because they had no education. And one of them was a nurse practitioner at my OBGYN's office. She said, oh, you could probably benefit from hormone therapy, but you're not a candidate. And I took that information, I ingested it, I believed it. And then the next stop was the urogynecologist's office, because I was wetting my pants, which I talk about pretty freely, not a fun topic, but whatever, it happens. I thought it only happened to people who had babies. I was wrong, it happened to me. And so the nurse practitioner there told me she wasn't sure if vaginal estrogen was safe for me in the urogynecologist's office as someone with heterozygous factor V Leiden. My message back to them after they informed me that I was responsible for doing my own medical research was that I implore them to stop giving their patients bad information. I expect them to do medical research and not have the patients rely on it. And then they sent me a note saying that they had some staff changes and would I like to come back? And I said I wouldn't go to your office if my insides were falling out, which I also put on social media without putting their names. I was nice, I blocked it out. You know, protect the innocent. But so self-advocacy and advocacy for all is just super important, and all of us can get involved. In fact, House Bill 4838 is still accepting written testimony through its mid to late March. So I encourage you, if you're so inclined to, please, you don't have to be based in Massachusetts, you can be from anywhere, please write in support of House Bill 4838, which will require CME, which by the way, ACOG is fighting against required CME. They've already contacted Assemblywoman Rosenthal in New York. They do not want forced CME. They think the onus, there's too much onus on doctors already with documentation and things like that. I say too bad, 51% or more of your patient base is female. You should probably learn how to deal with their bodies. So, but again, 4838, workplace accommodations, a task force or commission would be structured to really bring interdisciplinary folks together to study menopause and the impact on the economy. $1.8 billion in lost revenue for businesses due to untreated perimenopause and menopause symptoms.
Wow. Wow, wow, wow. So as the head of Women's Health Advocates, if you haven't signed up for our group, please do. It's womenshealthadvocates.org. We have a very powerful menopause committee that is focused on menopause legislation. We have several other committees on all kinds of issues, breast cancer, FDA regulatory, like basically any issue. Yeah, coming soon. And we had a recent webinar actually on censoring women's health and how AI is shaping what we're seeing, because there's a whole suppression, there's all kinds of things happening when we're doing these searches, just to add to that. Yeah, exactly. And then today, we are in Black History Month. We did a wonderful event today, actually, on Black women's health. So there's a lot going on with Women's Health Advocates. I just invite you to join our group. So now I'm going to turn it over to you all. Do people have questions? Just raise your hand, and we're here to answer any questions that you have. Yes. Brave. Very brave. Go ahead. I don't know if you have a...
Yeah, there's a
do.
microphone.
There's a mic coming your way.
There you go.
This is Kiernan. Thank you, Kiernan.
Thank you.
Yeah.
Thank you. So, thank you so much for the conversation over here, because this has been my lived experience with my mother. So I'm a physician by training, and I got into medical research trying to understand why we don't have the adequate information for menopause, because she was actually diagnosed with bipolar first, and then I had to advocate for her. As you said, I was in that position of privilege to actually go down a rabbit hole of reading the literature, trying to understand that this is not her problem. And the conversations we saw with the men was also a lived experience where our family structure also kind of crumbled, because women are community holders. They're the very essential backbone of our communities. So I wanted to explore how do we actually build social support systems and societal structures, because I was lucky that I was a physician. I was back in India, so we had a really tight-knit community of people supporting us. But for someone who does not have that and goes through this transition, how do you go about creating those community support networks for those individuals?
I think we all know that community is everything. And without our support systems, everything crumbles. For me, I found community online. I also had really good folks that I could talk to. In fact, the day before I woke up with my full face of facial hair, which sent me to the threading salon, My college roommate had said to me, hey, listen, I'm experiencing these things. And I was like, oh, nothing's happened to me yet. And 3 days later, I woke up with dark, fine hair covering my cheeks and neck. And so knowing that I had somebody to talk to was huge. As far as creating a more formalized community, I think what Anila's hometown has is really powerful. They get 140 women at every event that they're hosting. I think we all need to create that community if one is not already established. So with our privilege, we should find community and create it if we have to.
I'm really glad that you asked that question, because I had a little bit of issue with this documentary, especially that husbands group that they had, because they were kind of touching on the fact that they were saying, oh, it's not a me problem, it's my wife's problem. And I don't think that's the entire picture. Menopause is just one piece of the puzzle, but it can sometimes be a symptom of an underlying societal issue, which is women do take on a lot of responsibilities both inside the home and outside the home. And now that we have this women's lib and more women are in the workforce and whatever, we're taking on all those responsibilities, but the responsibilities at home aren't really going away. And I do think the generation of men now is much better than the generation before us. But there's still a lot of work to do. And so it's not just, oh, she's hormonal, that's why she's messed up or she's moody. It's, it could just be that she's got a lot on her plate. I always tell my menopausal women, you guys are the sandwich generation. You're taking care of maybe young kids or young nieces and nephews, but then you also have aging parents as well. So you are caretakers on both sides of the age spectrum. So that could be also something to play and something to recognize as a community. It's not just the hormones.
There's a lot of talk of gray divorce, right? It's like, oh, people hit menopause and they get divorced. I think a lot of times, people just are sick of other people's shit and they're just not gonna put up with it anymore. I mean, the number of people who are like, I'm done. I've got your mom, I got your kids, and no more. Pick up the slack. I'm not putting up with this. And people are like, whoa, what? And because they, a lot of the social media will say that women, start to really come into themselves at 40, and 50 is the new 30. All these different things are happening, but universally, I think we know what our options are, and we know what we're not going to tolerate, and with that comes some challenges in the relationships. So we actually contemplated having a man on the panel to kind of weigh in on it, and then we didn't.
No, I would say that you guys are hitting some really important points. We have this generation, particularly, they're the sandwich generation, but it's not just sandwich generation, they're isolated. It's like literally the first generation where there's no community unless you're building it very intentionally. So you're sandwiched, you're isolated, and you're perimenopausal. That's a powerful trifecta. So it's just building the community that you want to be in is, I think, a critical part of this, because the isolation, human connection is so critical. And I will tell you that I'm so concerned about the isolation of this generation because I've had people come in, patients come in, who don't even know what menopause is. Because that woman building collective community has not always been there. It's like, Gen X, we were the latchkey kids. So I literally have a lot of women who come in, and the reason that they find out they're perimenopausal is they're coming in for a pregnancy test. At age 48.
I have a friend who constantly takes pregnancy tests. She lives in a state where I would be cautious about how many pregnancy tests you're buying, but she's constantly taking pregnancy tests, and because she's 38 and perimenopausal. And I'm like, you don't have to do that. You could just maybe take birth control for now.
Oh, dude.
For now.
As soon as I had my son, I was like, get a NuvaRing up in there. I don't want another period until it's over. And I'm like, I was taking birth control. Trust me, I do not need birth control. I'm not that person. But it was relief to not, one less thing to worry about. You can have one less thing to worry about. How nice would that be? And the transdermal stuff, I think, is really critical for people. That's something that you'll have to talk with your doctor about, because a lot of us don't know about that. I remember I was blown away about how much better that could be for your body, because when you take a pill, it goes through your liver. When you put a patch on, it bypasses your liver. It doesn't engage with a lot of the augmenting behaviors that can cause adverse effects. So the more folks that use transdermal and have the conversations with their doctor, the more production that will happen. It's a game changer.
I mean, transdermal is what opened up the option for me. I wouldn't have had the option without transdermal as someone with a potential blood clot. We have another question.
Liz, I'm Shelley Amster, and I am not a physician, but I am definitely not perimenopausal. And I did want to bring up this chapter of a few of us lives that I think I want you guys to be aware of. Less than a year ago, I found out that I've had several silent heart attacks that apparently when they look back, I've had 4 EKGs that never were read correctly. And my cardiologist, who happens to be a chairman of the department, a personal friend, got me right in, and I was lucky. And he said, I can't believe that primary care docs and OBGYNs are not telling their patients to start taking statins and baby aspirin as preventative care after you have some blood work, and because it's just important. And so I just want to tell you that staying healthy, because I'm hitting a big birthday, and I'm trying to stay healthy. I'm still a very active athlete, and I urge all of you to stay healthy, because there's those of us who want to live. We don't want to retire. We want to keep mentally and physically healthy, and so I just encourage you to be lucky that you didn't go through what many of us didn't have available to us.
Yeah. I challenged some 23-year-olds, I think, to a plank off 2 days ago. Held my own. So it's pretty, yeah.
I'm skiing with a 5-year-old.
Who else do we have? Yeah.
Thank you so much for this event. This is great. Just my question is around, we're living in a time where the macroeconomic factors are that health insurance is now more expensive. So when we think about, economically distressed populations, that has to be a part of the conversation. And when we think about advocacy, where are we going to advocate for the funds to come from? Is this going to come from philanthropy, or where is this money going to come from to fund this? Thank you.
From a hormone perspective, part of House Bill 4838 will be a requirement for insurance companies to cover hormone therapy. Everybody should be aware that your insurance might not give you the best price for your hormone therapy. We all have to comparison shop for every single medication that we are prescribed. We might get a better price from GoodRx, we might get a better price from Mark Cuban's Cost Plus Drugs or Amazon Pharmacy, but legislation is happening right now that is going to require health insurance to cover these generic drugs, okay, without hopefully charging all of us a fortune. We are seeing wholesale prices go up on patches, but I mean, these drugs are not new. And they should be very inexpensive. Vaginal estrogen, I want to point out, vaginal estrogen, a relative of mine, who might be here, went to fill a vaginal estrogen prescription with the Medicare Part D program, and it was going to be $125. Okay, vaginal estrogen costs $13.21 per tube from Mark Cuban's Cost Plus Drugs. If it's not covered by your insurance at a very low cost, go to Mark Cuban's Cost Plus Drugs. I'm not advertising them other than I know that they have the most aggressive pricing that you can find. $13.21 plus $5 shipping per order, not per prescription. So they're unreliable for patches, but right now Prometrium, which is micronized progesterone, and vaginal estrogen are pretty reliable. You can get them pretty reliably from there. But we have to comparison shop always, all the time, but legislation is happening where they're trying to force coverage from insurance companies.
And I will sort of piggyback on that. Number one, I will definitely vouch for Mark Cuban. I'm not getting any money from that man, but oh my God, it's a game changer. So if you check all your medications, most of them you can get cheaper than your copay. And the really super geek advocate, there's a thing called pharmacy benefit managers. PBMs are billion-dollar businesses that are just a middleman that just take money out of the system and pump up the prices and get rebates. Any legislation that you hear about that involves PBMs, if it's against PBMs, make sure that your representative votes for them. Anything against PBMs, I'm just gonna blanket.
Absolutely.
So, like, Google it and call your representative. There's stuff in play right now in Massachusetts. I'm gonna make it simple. PBMs, evil, drive up prices, bad. It's a pharmacy benefit manager. It's people, your insurance company, they're the ones that make the formulary for your insurance company. That's sort of a simple way of doing it. And the way they do it is they go to that big pharma and that big pharma and they say, hey, you give me a little extra money, I'll put you on the formulary. That is exactly what they do. And they keep the money, drives up the prices, and they change the formulary yearly so that they can keep doing that. So, PBM's evil, vote no, or yes, whichever one makes them go away.
Yeah. Well, absolutely. You also have to look at the entire structure, right? So you've got a company that owns the insurance company, a company that owns the doctor network, a company that owns the pharmacy, and we have to know that none of that is to help us. None of that is just to line their own pockets. There is a special place in hell, and I'm an atheist, but there is a special place in hell for anybody who has PBM, and I'd be surprised if any of them have it on their LinkedIn profile.
No.
Yeah, 'cause-
Evil.
yeah, terrible.
Yeah, a question here. So I think, Andrea, I have a question for you. You mentioned how there's a worldwide shortage of estrogen patches. So I was wondering, and you did mention a little bit about, you know, why that is in trying to get pharmaceutical companies paid, but I'm wondering if you can maybe give a little bit more detail on it. Is it because it's a generic and that there's no incentive, or is it like, what's going to drive it? Is it legislation, or maybe can you just...
So my understanding, and there are people here who can address it if I'm not doing it right. So the orders had to go in years ago for these drugs in order for the production to really take place. And the orders just didn't happen. There's not a ton of revenue in these drugs because they are generics. You're not gonna see a commercial unless a nonprofit or something does it. You're not gonna see a commercial for menopause hormone therapy unless it's a drug that is not kind of naturally occurring, which is, I think, why they're not, you know, high volume, high revenue drugs for companies. So those orders didn't go in. And because nobody anticipated that the 6,000 women entering perimenopause on a daily basis would not want to feel like crap, right? So the orders didn't go in, the drugs weren't made, nobody thought they were going to be purchased. And so now it's going to take a couple of years for it all to catch up. So doctors are doing a bunch of different things. If you're on a 0.05 patch, that seems to be the hardest one to get a hold of. Some doctors might prescribe you 2 0.025s or a 0.1 and have you cut it in half depending on the kind of patch that you get. Other doctors are instead prescribing gels. There are some other transdermal options that are happening, and then some women there's going to be an increase in oral next. And then what I've heard is the next shortage will be micronized progesterone. So I have a stockpile at my house, and I encourage everybody else. I'll tell you a little trick. So if your doctor sends your prescription to Mark Cuban's Cost Plus Drugs, it doesn't go into that same pharmacy system that everything else does. So if you can get whatever you can from there, you get it from there. And then you go to your local pharmacy, you have your doctor send that prescription there. I couldn't get it from Cost Plus Drugs, they were out of stock. And then your doctor sends your prescription there, and then you fill it there too. You heard it here first people. So you just figure out, you work the system to get what you need to make sure you have.
Yeah,
Right?
you do get the 90-day supplies.
Yes, 90-day supplies.
Mark Cuban, best thing about him, 90-day supply shipped is the same cost as a 30-day supply. So 90-day supply, 90-day supply.
I get my minoxidil from there also, 0.02. You take a little half a pill a day, your hair stops falling out, and that costs me about $1.76 a month. If you really think about it, like if you really figure out how to work the system, you can make it work for you.
You have no choice.
I think. Yeah.
There's a question.
You're next.
Hi, thank you for this amazing session. My name is Anshul, So I have a quick question on the timeline of HRT prescription. I understand that it can start as early as perimenopause, but is there a deadline on the other end for a postmenopausal woman? And I would love to hear more.
Yeah, thank you for asking that question. So historically, it's a guideline, not a, again, not a word from God, but the guideline is as you approach between the ages of 60 and 65, the risks of hormone replacement therapy start to go up based on that problematic WHI study, and the benefits start to decrease. So the guideline is around that age is when we start to talk to our women about potentially tapering. In my practice, I actually have a lot of patients who fight me on it, and they're like, I'm gonna take this before I die, it's the last thing I'm gonna take. And I just say, just humor me and cut the patch in half and see what happens. And I would say there's a decent chunk of women who say there's nothing that happened, you're just saving me money every month, and they actually do fine. I have another subset of women who don't do well. They say my hot flushes came back, my night sweats came back, I'm miserable again. Okay, so now you failed that taper, and now your benefits have outweighed your risks. And so we just have a very nuanced discussion every year about whether or not we should be keeping that patient on hormone replacement therapy. Ultimately, do I want a 98-year-old on hormone replacement therapy? No, because her risks are gonna be much higher. But if she absolutely needs it and she is otherwise very healthy, then that can be a discussion between the patient and the doctor at the end of the day.
So if I can ask.
Oh, and also vaginal estrogen you can take forever.
Yeah.
That can be the last pill you take before you die.
My boss, who is 85 this year, has been on HRT since the whole WHI debacle. She's like, they'll get it out of my cold dead hands.
Yeah, there are the cold dead hands folks. I do like the approach of cutting back to the level that you need. I'm not going near it. It's okay. Don't worry. But in general, it's start before 60, evaluate at 65 to get the greatest potential.
You had yeah. Just been asking a question for a while. I feel like we kind of danced around you. I apologize for that.
So there's a lot of talk about perimenopause, menopause, which I feel is a blessing and a curse because anyone and everyone's talking about it. So do you have any guidelines on how do you wade through some of this information? Because you open Instagram, everyone is pushing a supplement, everyone's talking about wear a weighted vest to go walking, or do this, do that.
Yeah, so there's a bunch of different things. You should really look up weighted vests before you purchase one for yourself. There are a bunch of people who should not have weighted vests, okay? So for other people, weighted vests is great. They touched on it in the documentary about supplements, and again, I see a lot of people push supplements. Women in the United States have the most expensive urine of anybody else because most of these supplements are water soluble. We don't need them, and we pee them out. So just understand that most of the time you're wasting your damn money. And so there are a couple of things, right? We know in New England that most of us are vitamin D deficient, right? So I think universally, or almost universally, most of us are advised to take vitamin D. We hear vitamin B12 for cognition and a bunch of things. I mean, I've not heard of it really hurting people. And then just, eat food.
Right.
I mean, most of the things that we need, we can get from diet. There's fiber. If you're on a GLP-1, right, you have to prioritize fiber in a way that maybe some other people do. There's have to. But otherwise, I mean, supplements are just, they're not part of the FDA, right? That there's tested, blah, blah, whatever. That's just a money-making scheme. What we need is, like healthy balance in our lives, medications that work, that help us, and a healthy diet, and, take care of yourself.
Yeah, I think the best advice I've heard from someone was eat food, mostly plants, not too much. I can remember that.
Yeah.
Then I went and had a hamburger, but
Because it was delicious. It was delicious.
Moderation.
I mean, going back to your point about social media, I mean, menopause is a $21 billion industry. I looked at that statistic 2 years ago, and I think that's probably only gone up. And so there are a lot of players now trying to make money off of you, and it's really easy to just kind of click on that supplement. There are 2 sources that I get my information from. One is menopause.org, which is the Menopause Society's website, and all of their guidelines that I read is actually available to the public. And the American College of OBGYN, just because that's where I got my board certification, and they have a lot of information too. I think you probably need to pay to be a member, but it's not that bad. So those are the 2 like medical societies that I would get my information from. I would probably steer clear of supplement people trying to sell things. Anytime that you have a pay-to-play offer, that's usually a red flag.
And most of them are subscriptions, so just be mindful of, if you sign up and you don't forget to cancel it, they're just gonna keep sending you that garbage.
And hit the block button. If no one's tracking you, block it.
Yeah.
Follow me, you're not gonna see me pushing supplements.
Oh, another. We're coming.
Just a couple, I'm an OBGYN, and I've actually run a menopause consultation service.
This is Dr. Richardson, Dr. Marcy Richardson. I actually would like you to stand up because you're actually one of my inspirations. I used to shadow Dr. Richardson. I can't believe I just saw you. I just saw you. She's amazing.
She's my doctor.
But there are a couple of other resources. There's a bunch of stuff on women's health on the government, and I don't think Robert Kennedy's gotten to it yet, which is, and there's an International Menopause Society, which has a lot of short podcasts that are really excellent and that I send my patients to all the time. And this is a little bit of a self-advertisement, but I've been working over the last 5 or 10 years with a woman who started a website called womenlivingbetter.org. And she had the experience that many people here have described of going to multiple clinicians and saying, I'm having new anxiety, I'm waking up in the middle of the night, I can't go back to sleep, I'm a very happy person, I have a good life, what's going on? And so she went out and cold called a bunch of experts and has an evidence-based website, doesn't take any money from everyone, and it's specifically about educating about perimenopause. So it's called womenlivingbetter.org. And I have one more little comment, which is that I've really glommed on to not calling it hormone replacement therapy, because it's not hormone replacement therapy. It's estrogen therapy or estrogen and progesterone therapy. And we sort of morphed from hormone replacement therapy in the metaverse to hormone therapy, but hormone therapy is a little bit non-specific. So I actually like to call it menopausal hormone therapy, which is just mostly because it's not really hormone replacement therapy.
I've tried to use that, so you look at hashtags and which ones are most popular. I try to use menopause hormone therapy all the time in my social media, and sadly also have to tag HRT in it also, because the videos don't go anywhere, sadly, if you're using menopause hormone therapy. But that's the nomenclature that I attempt to adopt as well.
This is an opportunity for education.
Yeah.
And can I say one other thing, which is individualization in this space is really important. We're all different, and you do really need to find a clinician, and not necessarily a doctor. There are a lot of wonderful advanced practice nurses who are very, even in spite of your experience, who are very knowledgeable in this space. And also, there are so many data gaps. And I think you got that from the movie, because if you really were drilling down on what they had to say, there was a lot of vagueness about some of the things they had to say. So we got to keep doing research and trying to figure out what the real story is here. Thank you.
Yeah, I love that. I want to just touch really quickly on grifting and profiteering, which a lot of people see in the supplement space, but we also see it in spaces where people hang up a shingle and they're charging women exorbitant amounts of money for unnecessary testing. And that's a place where I rail against on social media all the time. When I first talked to my PCP after I had negative experiences at a number of different places, he said, "Oh, there's this doctor, you should go see her, and she's in Wellesley." And I called the office and they wanted $3,200 to see me and develop a treatment plan. And they said my lab work would likely be covered by my insurance, but then she would only prescribe compounded hormones that would not be covered by my insurance. And I'm really glad I didn't go to that appointment. It would have sent me down a path that is absolutely unnecessary. So I just, they use the term bioidentical in the film, and it's a term I have some challenges with because it is a marketing term. It doesn't have anything to do with science. All of the hormones, or the majority of the hormones that are most commonly prescribed now are bioidentical. They're all made in the lab. Everybody gets their APIs, which is like the primary ingredient stuff, from the same damn places. Okay, the same truck delivers it to the compounding pharmacy that delivers it to the company that makes the patches. So please don't fall prey if you're in need of care by a grifter or a profiteer. I recently was at an event where Anila's heard this story too many times. It was 4 people on the panel, one a nurse practitioner, practiced evidence-based medicine, she was good. The other one's a licensed clinical social worker, she was good, don't put yourself last, meditate, take care of yourself, breathe, great. But in the center were 2 RNs that had their own shingles up. Okay, so they've opened up their own practices. They can't prescribe anything, they're RNs. One of them puts a continuous glucose monitor on every single person that goes into her, into her practice. And then she monitors for I don't know what. And continuous glucose monitors are not inexpensive and are even difficult for people with type 2 diabetes to get covered by insurance, but she's putting them on everybody. And then the other one gives people supplements to prepare them for a hair test that she performs, and then that hair test will help her then figure out your mineral deficiency to cure your urinary incontinence. Now, I wanted to throw a chair, but I don't think I have a face for prison, so I just mouthed the words quack over and over at them until they were done talking. But what I don't want is for anybody to fall prey to that kind of profiteering and grifting. So, just be cautious.
Thank you guys for such an amazing event. My name is Lauren. I am a healthcare provider. I now work as a consultant across startups, mid-sized organizations, and universities, largely in the women's health space. And I'm deeply passionate about cardiometabolic health. One of the projects that I'm working on that I'm most passionate about is working with a large university. And what we're trying to do is figure out how do we create a place for the sex-based education to go into curriculum. And it's become a really, really difficult, almost onion of a problem, because in order to put something in, you have to take something out. And then do you start with the curriculum or do you start with the licensing boards? And how do we know the physicians, we know the providers need this education, but how do we get it to them early enough, way before that they would be looking for CMEs, in a way that still allows them to get enough education on everything. And I'm wondering from your experience, Anila and Renee, whether you have some ideas that this could be.
How much money do you got?
I know.
I was at the University of Minnesota. I was the lead physician at the Center for Human Sexuality. One of the research projects we did was evaluating all of the medical schools in the country for sexual health. And there's a paper. You don't have to read it. It was devastating. Minnesota had the most, and everyone else had nothing, practically. But if you want to influence a medical school and a curriculum, endow a couple of chairs and just say you have to teach this. And I'm just saying, if you can beg all you want, but they'll make space if you throw some money at them. I don't know if you have a couple million.
I wish. I would throw it right away. I mean, I loved in the video that they touched on cardiometabolic health or cardiac health, because that's the area of passion that I have. And I've asked so many physicians across the country, why is it that breast cancer has gone so viral, and why hasn't cardiac disease?
Money.
And it's money, and then you think about, you know, American Heart Association put a significant amount of money into their Go Red campaign, and it only increased awareness by like 40%, I think. And you know, you're like, what else? What other drivers can we use to get this out? And how do we do it systemically?
I think that the social media is a real important pathway. People advocating, stories, data, ask. One of the problems with the Go Red for Women is when you look at it on the URL, it says gored women.
Oh, really?
So you gotta have someone savvy with social media, like this one.
Well, I've worked in advertising for my whole career until I did this, right? So, so kind of coming up with a company name, doing all that stuff was very intentional, right? None of it was by accident. And so when you talk about throw money at them, like that's what you have to do, right? Like you have to be intentional about what you're doing. So we need the Melinda French Gates of the world to give money. We need Murray Schreiber. We need all these people who are experiencing this or have experienced it or love somebody who was born with ovaries, right? To start putting their money behind these things. I do have a question though, because you went to medical school at a time when this curriculum was still in place.
Yeah.
So what replaced it?
What
I mean, a
replaced
lot
it?
of advancement.
No, that's a great answer. I think that this young lady over here was talking about statins. A lot of the pharmacological, big pharma, a lot of the pharmacological inputs were hugely put in place. And there's been a really big push on standardizing curriculums. And so if everyone has to do it the same way, any sort of diversion, you really have to make a lot of effort to move that. And that's why I think one of the things that we need to keep in mind, I've been involved with organized medicine for a very long time. I've been very against legislative CME, except this case, and this is why. This change happened because of legislation and executive work. The federal government put a black box warning on something and shut down good treatment for decades. In order to correct that, we actually do need to have legislation in place that says, no, you have to learn this, and you have to teach this, and you have to study this, because we've let generations down because of the work that we did at our FDA. It was good intention, but it stopped things. So we have to jumpstart it. And like I said, I've been against legislated CME forever, except for this.
And actually, this is actually a bipartisan issue, surprisingly. So whether you're on the red or blue side of the aisle, there are people who are supporting this kind of across the board.
If you look at the current FDA, this FDA was a surprise for it.
Yeah, we're approaching 10 o'clock, so I feel like we probably should wrap up. But I'm going to finish on a positive note. I will tell you. So I'm a lobbyist, so I meet with folks on Capitol Hill and with the administration, no matter who's running things. I had some very positive meetings with the HHS leadership recently, who talks about how, you know, our secretary is all about food consumption and healthy eating, right? So they have lobbied really hard with the states that have the most medical schools to get them to change what they're teaching doctors to include nutrition. So they said to us, because, you know, we gave them all, we were supposed to meet with them for half an hour, we met for an hour and a half. They took tons of notes, they were all engaged. They said, we just did this for nutrition, we can do this for women's health. So they're very interested in working with us to actually change the curriculum. We're also working with them on some other interesting things. They're very fired up on sex as a biological variable, which has been the law since 2016, but isn't really followed. And so there's a lot of frustration with that. How do we actually get that to happen? Do you know in clinical studies right now, only about half the time, they're generating the data based on sex aggregation. So only half the time we're actually using that information to inform labeling, etc. Menstrual cycle, hormones, all that kind of stuff's not even asked most of the time. So like we still have a ways to go, and that's why we're advocating. But just know, people are interested, and it just takes some education. A lot of repeat that education. But we can pull folks over, both sides of the aisle, to your point. This is very bipartisan. So get out there, use your voice, be an advocate, no matter where you are in your life, in your journey. Know that women's health advocates would certainly be eager to work with you, but you can do it through your own organizations, your own communities. Your voice matters. If nothing else, I want you to walk away with that tonight. And thank you all for coming.